I'm Sue Landgraf. I'm the Executive Director of Cystic Fibrosis Research Incorporated, CFRI, based in Palo Alto, California. And today I'm going to talk a bit about advocating for rare patient access in Medicaid, but it really is more specific to advocating for patients that have an FDA-approved drug but cannot get access to it. So we'll just kind of get started, and it's kind of a mishmash of everything you've learned today, the personal story, advocating, the importance of telling your story, being proactive, being persistent, making an ask, having something to advocate for, and then you know what? There's always something else that can come out of that to advocate. So we'll just kind of work on this together, and I'll try to keep it short. So again, that's what we're going to do. So why me? Here I am, CFRI. We were formed in 1975. When we were formed by a group of parents who had children with CF, and at that time the kids were not expected to live past age 11. But that has changed, and we now provide education, support, awareness, we fund research, and most importantly, or one of the most important programs is 2 years ago we started an advocacy program. And I've been the ED since 2013, but I've been involved in CFRI for over 26 years while I was working in other nonprofit positions as a volunteer. So I wear two hats. They call me Two Hat Sue. Well, I have more hats than that, but we won't get into that. So I've worked with Medicaid-funded state insurance programs in California, Oregon, Arkansas, Texas, Tennessee, and Utah to alleviate those barriers to accessing FDA-approved medication. So that's my professional hat. My second hat is that I am the mother of a very beloved and precious daughter. She's an adult now who has cystic fibrosis. So I know quite a bit about this disease. So how many of you were able to see Jerry Cahill's documentary last night? Phenomenal. I know Jerry. That is a phenomenal documentary about what life is like with CF, but it's not the same for every person. There are about 2,000 mutations, so it's an individualized disease. Some people don't have it quite as bad as others. Some people don't get diagnosed until they're older. My sister got diagnosed 2 years ago at 62 with CF. So it can take all shapes and forms, but there is one thing that it's kind of a constant, that there is no cure for it. We were going to do a community icebreaker. We don't need to. We've broken the ice all day long, so forget that. Okay, so what is CF? So I get to kind of, give my spiel. So it is, if you didn't know it is the most common fatal genetic disease in North America. It affects 30,000 people in the United States, a little over 70,000 people worldwide. Both parents must carry the gene in order to produce a child with CF, and you have a 25% chance that their child will have CF. So my husband and I got lucky on our first go around, and we have a daughter with CF. So I don't know if you know this, but 1 in 31 people are silent carriers of the gene, and so there are quite a few people in here, based on probability, that are a silent carrier of the CF gene. So what's so bad about CF? Well, it kills you. That's what's so bad about it. It's a systemic disease. It's not just a lung disease. It affects every part of your body. The defect causes very thick mucus. It clogs up the ducts in your body. For the lungs, it then creates inflammation and scarring and wonderful pools of mucus that can harbor bacteria, and that's where you get all the coughing. You try to expel it. You get chronic exacerbations, inflammations, and scarring, and your lung function continues to go down over the years. CFers take 7 to 20 medications a day, multiple times a day, depending on if they're healthy or not. They might have in-home IV treatments. There's several times a day chest percussion airway treatment. When my daughter was young, we did it by hand, and you positioned the child in 20 different positions to tap out the mucus, and that they would cough that up. Then you came to the mallets, these little rubber, we called them cups, and we did that. Now they have vests, and they have all sorts of machines that can do it for you, and you can watch TV. But it takes a lot of time taking care of yourself and having CF. It really is a full-time job, and there are many hospitalizations and due to the infections, and many people need supplemental oxygen as their disease worsens. Okay, let me go back. This little boy here, he's one of 8 kids in his family. They live in San Jose, California. He's on the list for a double lung transplant. His sister, who you can't see there, she passed away a little over a year and a half ago from acute rejection. She'd had her lungs for 2 years. So they are Hispanic, and that is the fastest growing population of newly diagnosed individuals with CF. But they're just a wonderful family, and we're all quite close. That's the CF community. So like I said, it's having CF as a full-time job. As it progresses, it takes more time. People don't work. They don't have the energy to work. Many go on disability. It's emotionally devastating. It's very, very isolating. It's extremely painful and extremely expensive. So the primary cause of death is pulmonary failure due to inflammation and infection of the lungs. The median age of death is approximately 29 years old. That's not very long. The CF community, we are very fortunate that we have quite a few medications that can help us, but again, there still is no cure. So this is why I do what I do. This is my daughter, Victoria. At age 12, she went into unexpected liver failure, had a successful liver transplant, kind of just had a wonderful life after that, went to college, UC Berkeley, married, has her children, which are hairy, and they walk on 4 legs. But 2 years ago, in June of 2015, she was in end-stage CF. And she had a cold. She thought she was over the cold, but she's kind of stubborn, and I think she gets that from me. She thought she could get over it, and she couldn't. So she checked herself in on a Friday to her CF center. On Tuesday, she was in full pulmonary failure and was placed on life support. And we were told to say goodbye to her, that she would not come off life support. She was dying. So believe it or not, she fought back, and they eventually took her off life support. And 4 weeks to the day that she was admitted, she received a double lung transplant. And I asked her surgeon, I said, how much time did she have left? And he said to me, she did not. And so again, it came just in the nick of time, but she is enjoying her life again. This is Paddington Bear, one of her children, and one of my grandpups. The other one is Oliver. This clicker doesn't like me. There we go. So let's get right to it. So there are roadblocks in life, and one of the things that the CF community is facing, and I'm sure that there are a lot of other rare diseases that are facing similar situations like us, is that there are FDA-approved drugs that have been approved for use, but the state Medicaid program is denying access to them. So this is really a conundrum. The FDA has approved the drug, but that does not guarantee access to rare disease therapies, particularly in state Medicaid programs. So why is that? So I guess the system is a little bit broken. At least I would say so. So the state Medicaid programs have extremely powerful, and they're very powerful, drug utilization review boards or pharmacy and therapeutics committees that determine medication coverage. Now notice I said boards and committees, so that's kind of key here. These are roadblocks, so we're going to be a little interactive here. So when I raise my hand, I want you to say roadblock. It's very simple. It's the end of the day. So the Medicaid coverage decisions for these therapies are often made through opaque processes and without input from experts in their rare disease states. Roadblock, right? These boards rarely include rare disease patients, clinicians, or advocates. Roadblock. Many lack clearly defined processes for coverage decisions, roadblock, and they usually do not provide opportunity for public or clinical experts to provide input. Roadblock. What do they know about our diseases and the medication? There we go. So that leads to road rage. So many state Medicaid programs will put restrictions on access not consistent with FDA criteria, meaning that they can take a drug that the FDA has approved that has no restrictions whatsoever, and they put their own criteria on it, which is a real problem because you think that now you have this drug that's treating your disease, yet you can't get it because your state Medicaid program has imposed, or the committees have imposed that you have to have this test or your lung function has to be like this, or whatever. So this is a real big problem for our community. Decisions are left to those that typically do not have rare disease expertise, thus the need for policy changes, perhaps like the Expert Act followed by the FDA, and yes, there are supposed to be 2 R's in there, as I told my husband. So what is the Expert Act? I am not a policy expert, but it is an act that was adopted in 2012 that promoted the FDA working with rare patient disease experts and rare patient advocates and rare disease patients while going through the drug review process. Now, does that make sense to you that they would involve experts in the disease field? Makes sense to me, but unfortunately, in many of the states, the Medicaid systems, their systems lead to policies that are inconsistent with real-world clinical practice and harmful to patients because they don't take advantage of those people that are suffering from the disease or the people that are the experts in the field. It's the end of the day. So how to reduce barriers to access? Well, we at CFRI, we monitor state Medicaid sites for their meetings and agendas. We advocate for access, hope, and health. We increase awareness of the negative impact that their decision will have on our community. And again, that's telling personal stories. But it's also, we have made the commitment to approaching the pharmaceutical companies, experts in the field to get their take on what's happening and how does it really harm the patient, so that we have all of our ducks in a row before we approach the Medicaid program. So we're proactive, we're persistent, we contact multiple individuals, the DUR boards, P&T committees, medical directors, and we never forget our state and federal legislators. We'll copy them on what we're doing. We send emails, we do letters, we do phone calls, and we call personal meetings. And those personal meetings are very, very important, like we're all going to do tomorrow. And you want to tell your story. How many times have we heard that today? Tell your story. But it's true, okay? So what we do is we educate these committees and boards about CF. We serve as a CF rare disease resource and expert so that hopefully we can talk some sense into them. We give specifics on the harm that's caused to the CF population for whom the drug is intended and who cannot get that drug. And you always need to make an ask. So we ask them to remove the barrier to access. We offer to work with them to give testimony during their review process if they have one open to the public. But your letter might also serve as public testimony. Oftentimes, if I'm working out of state, I'll find a CF advocate in that state to testify if they have a public forum. We ask CFRI's constituents to send letters if needed. We always, what's that word, follow up. And we continue to offer assistance to find solutions, and we're persistent. So that's how we work through this problem with the Medicaid issues. So currently I'm working with California's Medicaid program, the Genetically Handicapped Persons Program, and the California Children's Services Program. They added restricted clauses to Orkambi, which is one of the two drugs created by Vertex that get to the root cause of cystic fibrosis. So it's not a cure, but it's the closest thing that we have for a cure for a certain population. So they decided to add, even though the FDA approved it, saying, here's the drug, take it, go use it, you know, get healthy, help these people, they decided that they would add some restrictions to that. So I contacted the medical director for a meeting, and I brought along a 17-year-old young man who suffers from CF. And his life story is every year he's been in the hospital for 4 to 6 months. His body weight was horrible. He was schooled at home. He had no friends. He really didn't have a good life, but yet he'd managed to keep his lung function up pretty high, which was surprising to me. But he was put on Orkambi through private pay insurance, so he didn't have to go through the Medicaid route because they would have denied him access to the drug. After 1 year of being on this drug, his body weight increased 60 pounds, which is unheard of in a person with cystic fibrosis because part of the problem is malabsorption of food. So he gained 60 pounds, his lung function went back up over 90%, he had no exacerbations, he didn't need any antibiotics, he hadn't been hospitalized. So for the first time in 16 years, this kid had not been hospitalized. So we talked with the medical director and we stressed, that he needed to act, and it was urgent to save the lives of those affected by CF. So the end result is that he decided that he would call a meeting of the CF centers in California, us and himself, and that was in December of 2016. And so we had a really good outcome. He dropped the restrictions that they had placed on pulmonary function tests for children to age 20. So that was a real coup because it was going into the cold and flu season and these kids were being denied access to this drug. And then he agreed to work on the same for ages 21 years and older. So that's where we are right now. We're working to get data from some of the CF centers so that we can supply him with that data, so hopefully he will drop the restrictions and that drug will be made available. So that's how we advocate in with our state Medicaid program in California. But there's not always a happy ending. As I said before, sometimes when you're advocating for something, it can lead to something else that you can advocate for. So here's something that I think we need to do. We need an advocacy movement, and I think it's already started, to push Congress to encourage state Medicaid entities to incorporate the Expert Act. So what does that mean? Develop an open, transparent procedure for coverage policy determinations, include public, patient, clinicians, and manufacturers' perspectives during the drug review process, and that really is critical. Include on the DUR and P&T committees relevant expert specialists for that particular disease group and drug, absolutely necessary. Make the draft policy public and ask for public testimony on the draft policy. And then before making the final decision, return the policy to the DUR board and P&T committee for a review and vote, but only after incorporating those first steps. So, you know, we have our work cut out for us. But this is a great group, and I know that you're not all affiliated with CF. You all have your own rare diseases, and I know that we're fortunate we have more medications. But someday I'm hoping that you will have the medication. But I guess what I'm trying to say here is even if you don't have medication, we can work together to advocate on a national level to get the Expert Act included in the way the state Medicaid boards or programs do business. So I appreciate you having me here today. And if you have any questions, I will try to answer them, and I'll be honest if I don't know the answer.